So UNICEF and DO Care have partnered up to have Dr. Nicholas Comninellis present to us on the controversies of short-term medical missions today. And he's good at giving his own introduction, but just a little bit about him. He is an assistant clinical professor of community and family medicine at the University of Missouri Kansas City School of Medicine, and he's the founder of the Institute for International Medicine. So if any of you have heard us throw around the more abbreviated title Inmed, that's what we're referring to. So without further ado, let's give Nicholas a warm welcome. I was going to say round of applause.
I love coming up to visit you all. As a student body, I love your altruism and your energy and vision, and not every school is that way. Well, this is an era in which we have witnessed numerous disasters. So you remember Port-au-Prince, you remember the other earthquakes. There was an Indonesian tsunami 5 years ago. This was one of the most heartbreaking things I saw when I was working in Africa. My story begins with a biography, and it was Tom Dooley. He was a real-life St. Louis U physician who spoke French and was in the US Navy, and they were working in Vietnam. This was just before the outbreak of the Vietnam War. Well, being a physician and being French-speaking, Vietnam had been a French colony, they called on Dooley to run the refugee care of North Koreans or North Vietnamese who were fleeing to the south. And so these were people who were hungry, who were ill, who could not find their children, who had no home, who were barely surviving. And as they proceeded southward, they would come under Dooley's care. And in his book, he writes about just massive acts of compassion to these people in such desperate straits. So I was looking for opportunities to emulate Dooley as a student. And it began at a maternity hospital in Haiti, where they were delivering babies, but they had no gloves. And they had newborns, but they had no blankets in which to wrap these infants. Well, the following year, as a senior, I was at the Clínica Evangélica Morava on the eastern coast of Honduras working with Sam Marks, an American doctor who had been there for 30 years. And his situation was a little bit better because he had had such a long time to invest in caring for these people. And as a student, it was extremely formative. I delivered my first baby. I did certain procedures I had never thought of before. And I thought, so far, international medicine is tasting just right. So as a resident physician, I was looking for the very poorest nation on the entire planet. And I chose Burkina Faso, which is West Africa, hot as can be. And I would see almost every day children like this. So this kid has a lump on his head, several lumps actually, and they're warm and they're tender and they feel fluctuant. And so like any good clinician, I figured this was an abscess, sure. And so I numbed it up and I incised it, and out came a big white worm, exactly. So this was onchocerciasis. And I realized at that moment, I've got a lot to learn about this kind of work if I'm going to get serious about it. So then I moved on to the Charity Hospital in Shanghai. The U of Missouri had a relationship with them where they were exchanging personnel. And so I spent a couple of years at Shanghai Charity where we were mainly caring for people with schistosomiasis, tuberculosis, and rheumatic heart disease. Classic diseases of poverty. And so in the case of China, today, of course, there is great wealth. We see pictures of skyscrapers and construction cranes, but there is still great poverty. Some provinces of China have poverty levels that are equal to rural Africa. And after my term of service there, I moved to Angola, which is this nation in southern Africa where I spent 3 years. And in Angola, we had an entire country with no functioning government. Money was useless. There were no banks. Schools were entirely closed. And there were landmines throughout the nation. Well, in '04, I came back to the U of Missouri and lived in Kansas City and then launched the Institute for International Medicine. So I made a lot of mistakes. You know, I should never have incised that poor kid's head. And other bigger mistakes than that. And so my vision was really to equip people to be able to do this kind of work in cross-cultural, low-resource settings in a way that is more effective, that is more ethical than what I had experienced by trial and error earlier in my career. Now, we deal with a lot of stats at Inmed, and one of the obvious statistics is that women live longer than men, and some of you know why. You know, guys are predisposed to certain kinds of activities. You know, we see a problem and we think to ourselves, I know how to fix that. You know, give me some duct tape and super glue. And, you know, do you see women doing things like this? No, no wonder guys don't live as long as women. All this can start very early. And I find this one particularly shocking myself. What were they thinking? And this has all been going on for a very long time. Guys putting themselves at needless risk. So, statistics. Well, about 5,000 teams leave the United States every year and travel to another nation with wonderful intentions of providing some medical care. Now, often this is episodic care, where it's sort of drop in and drop out medicine. And the enthusiasm surrounding this is just unstoppable with the number of teams that usually go out for a week or two in duration. Well, why is it that people are so fascinated with doing this? How many of you have been on some kind of short-term healthcare team? So what is the draw? Just raise your hand and shout it out. What's that?
It fits into a vacation time.
Okay, fits into a vacation time. Thank you.
You get a lot of clinical experience that you wouldn't get here.
Good, thank you.
You see things that you wouldn't normally see in the United States?
Yeah, see things you wouldn't see in the States.
You get to help people who don't normally have access to care.
Helping people who don't normally get access to care.
I think a lot of us are on time constraints, and so it fits well within a certain limited amount of time that we have for free.
Sure, it fits into your vacation time or your break time.
You might be giving more opportunities or responsibilities that you wouldn't necessarily get at your level of training here in the States.
Okay, you might have opportunities that you wouldn't have necessarily with your current training. Yeah, excellent. And there is certainly an element of compassion and desire to meet people's needs, but honestly, there's also a certain amount of adventure and travel and exotic culture that is a draw as well. Well, there are clearly people that are benefited from this. So from their standpoint, what are the benefits?
Access to medications that they don't have access to?
Okay, maybe they'll get medications that they wouldn't otherwise receive.
Getting to actually see a physician.
Getting actually to see a physician. So many times these people have never seen a physician in their life. Yeah, please.
Helping establish clinics using people who are locally there, helping them get it up and running.
Okay, helping local people to establish healthcare that might be sustainable. Yeah. And as we do this, we certainly are showing some compassion. There will always be an anecdote of someone who was aided because of an outsider who's visiting, and maybe even contributing to the local infrastructure. There are also some shortcomings. And as you have experienced these trips yourself, what kind of frustrations or downside have you witnessed? Yeah. What's that? Supply can't meet demand, yes. Language barriers.
A number of things that would be potentially easy to fix here, not having the equipment. And things like
Yeah, not having the equipment, the resources that we're used to using. And so these kind of barriers really do require some thought. You know, often there's not a lot of concern given to prevention or attention, and are we contributing to any kind of actual long-term solutions for the benefit of these people? There are benchmarks that we might ask. how are we going to evaluate the success or the effectiveness of this short-term medical adventure? By what criteria could we do that? What do you think? How do you know if it's worthwhile or not? Yes?
Be good to see it a year later.
Okay. Compare it with the next year. Yeah.
Follow trends in health statistics for that area.
Okay. If you can collect health statistics, what's the change over time in that area? Yeah.
Ask the community.
Oh, there you go. Well, let's see. Yeah, on a scale of 1 to 10, how do you think we're contributing? You know, or what kind of comments do the recipients have to say about this? And similarly, you could also ask about the participants. You know, was this a satisfactory experience or not? Numbers of procedures, number of people that were seen, you know, just data on services provided is sort of easy to measure. But this whole thing of increasing the community's health status, that's very daunting, both to measure and to actually effectuate. Acts of compassion. Really, in many cases, all that the trip leaders are trying to do is just to show some compassion. You know, and they're very upfront about that. We may not actually contribute to the increasing health status of the community, but at least we're being kind. So in the context of benchmarks, let's ask ourselves a few questions. You know, would it be actually effective to give deworming medication to children, but not address the lack of safe drinking water, which is how they're getting their worm infections? You know, would it be effective to find somebody who has diabetes, and there is just as much diabetes in poor nations as there is in the West, but yet not be able to provide them any kind of continuity of care, let alone medication, for their diabetes? You know, similarly, children with diarrhea illness, so we can give them oral rehydration solution, but what underlies those illnesses is often malnutrition. And so what are we doing about malnutrition? We can treat their malaria. What are we doing about preventing their malaria? You know, moving one step beyond the physician-patient encounter. So those are some of the effectiveness questions we can ask. There are also some ethical issues. What kind of dilemmas have you come across as you've been engaging in this kind of service? Yeah.
I think when we were in Nicaragua, we worked in a prison there, and they had us take an hour out just so all of the guards who did have medical care and access to you know, doctors and physicians, none of the prisoners did, but they still wanted to be seen by American physicians.
Excellent, excellent. So working in a prison, and the staff of the prison got first priority in being seen before the prisoners. Yes. That's wonderful. Another ethical dilemma? Yeah.
I don't know if it's like the ethic, like if it's ethical or not, but not necessarily that issue, but just most of the time I felt like I was just giving education. Like a lot of people coming in thought they had UTIs when really it was just like they weren't hydrated, really. So I don't know, I just felt like maybe it would have been more ethical to just like have classes about like how to take care of yourself rather than like treating in an acute setting for a lot of just like what probably would have gotten better just with education.
Yeah, and so the tension between people needing education versus just treating what they perceived as an acute problem. Yeah. Yes?
I guess there's some ethical dilemma about the cost of the mission itself.
Mm-hmm.
Because, for example, like some people might do an analysis and say, well, for all of us who went on this trip to this orphanage to help them, we could have provided food for 2 years for them, given the money that we spent to fly there.
Yes, so the money that was spent on travel could have been used for something else, maybe more effective. One more, yes.
I worked in an area where the culture was very religious, and we were diagnosing illnesses in women like STDs. A woman who was married and faithful and had to discuss the idea of fidelity between her husband and her husband not being protected when having sex and things like that. But because of the religious culture, it was very difficult to have those conversations.
Okay. Yes, thank you. So in a situation in which someone has a sexual disease, but the culture does not permit it to be discussed or to be communicated. Yeah, excellent. And for us as travelers, there are also often questions that don't even get asked, like, do you actually need a license to practice? You know, so if you go to Guatemala and provide charity care for 10 days, do you need a Guatemalan medical license? You know? Similarly, we as teachers often will allow students to do things without supervision that we normally would never do, you know, back in the States or back in a more formal school education. This whole thing of culture is very, very sticky. So Inmed partners with the Imsilini Hospital in northeastern South Africa. That's the region of the world that has the highest prevalence of HIV. Some like 40% of individuals are HIV positive. So we have a public health specialist who was preparing to work there, and what he found was that his presentation about sexual practice was entirely inappropriate in a culture where actually fathers intentionally instruct their children, their boys, to get involved in sex, you know, at as early as possible. That's just their culture. And, you know, and so how can we as an outsider come in and say, I understand this, when often we don't take the time to study the culture? Medications. Nancy Krieger is on the Inmed board, and she describes the situation in Honduras where a physician saw someone with peripheral neuropathy. Well, thoughtful doctor had brought some Neurontin with them and gave the samples to the patient. Well, then the team departed, and then the woman developed some adverse effects from the Neurontin. Well, nobody knew what to do with that. You know, rural Honduras, what do they know about Neurontin in rural Honduras? And so the conclusion here is it probably wasn't ethical to do that in the first place. You know, to give them a medication that they wouldn't be able to continue taking, and to not having any monitoring. And so sticking with the WHO essential drug list is a really good idea in a low resource setting, because those are drugs that almost everyone is familiar with already and could potentially alleviate that problem. Well, there are questions of cultural relevance. When we try to provide care, we come across, even in the United States, all kinds of cultural misunderstandings. Look at vaccinations, for example. Yes, they have a problem with people accepting vaccines in Southeast Asia, but gee, we have problems every day with people accepting vaccines, you know, even within our own culture. And so the people in South Africa, this was the Zulu people that he was trying to instruct about sexual abstinence. Didn't go so well, even though they listened politely. We want to provide care which is effective, which is ethical, which is culturally relevant. How are we going to do that? How are we going to reorient our approach? Well, to get it right, I recommend we do two things in particular. We form partnerships with our hosts, very close partnerships with the people who invite us. And then we commit ourselves to some continuity with those hosts. So in the context of partnership, we have hosts who can help us understand what is culturally relevant, what is acceptable in that community, what is actually going to be effective or ethical in that particular setting. And so rather than us going in and saying, this is what we're providing, here it is, instead we ask questions like, what do you need? How can I help? What do you think my role could possibly be? Who could you partner with? When you think about working in the developing country and you were looking to find a host, what kind of individuals or groups could that be? Yeah.
Community leaders.
Community leaders. Who else? Who would have an interest in the health of their community? What's that? Religious leaders, yeah, civic organizations, Rotary clubs, churches, yeah.
Local doctors or healthcare providers.
All right, the local healthcare establishment. Yeah, you may find government health agencies, you may find UNICEF, NGOs, and forming partnerships I found is usually not that difficult because it really makes them look good. They will like to work with you because it enhances their own stature as well. But this is a perfect opportunity to embrace the virtues of humility and deference. Because when we come to them and we say, how can I help you? What would you like me to do? We're showing enormous respect. Some of you are familiar with Philippians, where he says, do nothing out of selfish ambition or vain conceit, but rather in humility, consider others above yourself. And so with that kind of attitude, we can go to a partner and we can say, how can I assist at your facility? It's yours. What do you want me to do? Well, they might actually want you to do manpower. They might want you to do patient care. And so that might be, outpatient, urgent care, surgery, some kind of community development thing where they're actually using you as manpower. And that's often what happens, but that is not the only avenue. Maybe what they really need is supplies. Maybe they need gloves to deliver babies or blankets in which to wrap those newborns. I appreciate what you said about the cost that we spend on travel. Maybe some of that money could actually be reallocated to providing equipment, supplies that they need. And it's not only bandages and vaccines. Maybe what they need is education materials or internet access or something involving disaster aid, water supply, food assistance. There might be a subject that they need to learn, that they want to learn. As you know, many newborns die right after delivery because they're not adequately resuscitated. They just need to be dried off and maybe a little bag and mask, and they start breathing on their own. And so if you can teach midwives how to resuscitate newborns, you could give them a skill that could potentially save many, many lives. Similarly, the courses that we take in the United States on cardiac life support, trauma life support, have been translated into other languages. So if you want to teach ACLS in India or China or Pakistan, they've got the curriculum available for you in order to transfer those skills to someone else. Maybe what they actually need is not generalists to see primary care patients, but rather some specialists who can take care of their people who are blind. Maybe they need someone that can do plastic surgery or that can do a fistula repair. And so the role of eye doctors and plastics doctors and GYNs, can, in just a very short period of time, just a few days, really revolutionize the lives of many individuals. And while we're asking how can we assist, it's also good to ask, what can I learn about you to better serve your people? Deference. Tell me about your holidays. Tell me about your children. What do your teenagers dream of? What do your older people struggle with? As we get to know them, we're going to be more effective not only in our medical care, but also in our relationships with them. Find a partner and ask them how you can possibly participate. Now, how are you going to do that in 5 to 10 days? Well, you've got to add to this an enduring commitment with a long-term view. Now, how's that possible? How can you integrate a long-term view into short-term service? I want to give you a few examples. One is Tim Myrick. He is a physician from Kansas City, has a family, and for several years, what he was doing is working in Somalia. Yeah, that's right. Now, he didn't bring his kids, but what he did was every quarter, he took 2 weeks, and he flew out there. And so for 6 years, he was spending 2 weeks teaching at the medical school every quarter. They gave him the neurology and the cardiology curriculum to communicate to their first-year students. And then in the afternoon, he was doing clinical care with their more advanced students. At the same time, he still had kids in high school in Kansas City. Yeah, 2 weeks every quarter. Who's familiar with Heart to Heart International? Heart to Heart is based in KC, and they are primarily involved in international relief. And so when there is an earthquake, a crisis, a tsunami, Heart to Heart is there. Well, after the Port-au-Prince earthquake, the trauma victims were cared for, and the cholera was under control, and all of the relief operations were winding down, and all the international volunteers were going home, and the country was decimated. So what Heart to Heart said was, this isn't good, we're going to set up primary care clinics. And so in 10 different locations in Haiti, they've got these clinics that run continuously. And so if you are interested in volunteering with Heart to Heart at one of their primary care clinics, they have a schedule and they'll slot you in for a week or two. And they do that with hundreds of healthcare personnel. And in that way, they're able to keep these clinics staffed on a continuous basis. Maison de Naissance, and we have Globe Med from Truman here with us today. So happy you joined us. So this is a birthing center in Haiti. It started off with a Kansas City OB and a Kansas City neonatologist who were going to Haiti for a week at a time and taking care of sick kids. And after 3 or 4 years of that, they decided, there's no way, we're not actually helping anybody in the long run. Instead, what we're going to do is work together with the Haitians to start a birthing center. A place that women can come and have their kids with some semblance of modern obstetrical care, gloves and blankets to provide for these people. So Maison de Naissance now has been operating over 10 years, delivered 1,000 children in almost American standard circumstances, and it's all run by Haitians. Now, the neonatal and the OB are still involved. They go down there and they do teaching periodically. But it is owned by the Haitians, it's funded by the Haitians, and it's led by the Haitians. A beautiful story of continuity over a period of time. Well, changing our approach to short-term missions. So we want it to be ethical, we want it to be effective, we want to be sensitive to the cultural situation. We do that through partnerships and an ongoing kind of commitment. Ask them what they want. Ask them how they want you to serve. One of the greatest opportunities to get involved in this is coming up in May. It's the Exploring Medical Missions Conference. Inmed hosts this every year, and it's an opportunity for you to meet people that are doing this kind of work, and also those who are leading sending organizations. And so Heart to Heart will be there, and Maison de Naissance will be there, and you can actually meet them in person and talk with them about how you can get involved. There is a discount code, EMMC10, that you can use when you register, and I have some of these cards in the back of the room. I hope you'll join us for this year's Exploring Medical Missions Conference. Inmed also provides a course in international medicine and public health, and some of you have already taken this. Let's see who's taken the course. Yes, thank you so much for being here. So we offered this in last fall, and it's going to be coming up again. We touch on the subjects of diseases of poverty, disaster relief, cross-cultural skills, HIV medicine and low resources. And the online section starts the end of August, and it's 10 weeks online. It takes 5 to 10 hours of work each week to get through the assignments. And then we bring you all in together for a weekend in which we do the hands-on skills that you can't do online. So I'd love to have you join us for that. And then if you take that kind of academic background and marry it with an actual service learning experience, a rotation, then you're really golden. And so we have faculty in 25 nations that will be your preceptor. And so if you want to go to Kenya and do surgery, or Tanzania and do OB, we have got a faculty there who would love to make that possible for you. And then we recognize our graduates with a diploma in international medicine and public health. Now, Inmed doesn't do group trips. As a learning experience, we think it's more powerful if we send you 1 by 1 or 2 by 2 to work with a preceptor, where you're going to get more attention than you would in a typical group setting. Not only do we have a diploma in international public health, but we also have an international public health diploma, which is designed for undergrads and for RNs and for those in physical therapy and healthcare administration. So in a few minutes, I'm going to tell you a story, but before I do, I want to just pause for a moment and ask if you would be thinking about a question that you may have, or maybe an experience that you want to share. Those of you who've been through the Inmed course, you might think of a comment you might have for the group. And so I'll come back to that in a moment, but I want to tell you about John the Baptist. It's not actually this John the Baptist. It's a man named John the Baptist, João Batista, that I met in Angola. And so he was a middle-aged farmer. And like most Angolans, he lives on corn. And so he put his seed corn into his bag, and he said goodbye to his children, and he went out to his field with his hoe to plant his corn. Well, I mentioned Angola is home to landmines. Angola had more landmines per capita than any other nation in the world. Princess Diana, just before she died, was in Angola to highlight this epidemic in that nation. And so there are many, many woefully maimed people in that nation because of the landmines. Well, so John the Baptist went out to plant his corn, and he didn't come home that night. And his children started wondering, where's Dad? You know, what's happened to Father? And so they went out looking for him, and they found him laying in the mud, covered with blood, because of this. And so they picked up their father, and they brought him to the Kelokim hospital where I was on duty. He had no blood pressure, thready pulse, and so we started his IV fluid, and we finished his amputation, and I figured he would not survive. But the next day, there was this man sitting up in bed, and he was looking at me, and he says, "What are you doing, white guy in Africa? Don't you know we have a war going on here?" I knew then that he was going to make it. So, and he did make it. Actually, several weeks later, he left the hospital on his crutches, and the war escalated. I had to leave. But for the last 12 years, I've been able to go back to Angola every summer. And last year, I was back at the Kelokim hospital, and there was this older man. He came up to me on crutches, and he said, "Hey, remember me? João Batista. Yeah, I heard that you were coming back to Angola, and I wanted to come back and just say thank you." Short-term investment, long-term impact. So what sort of questions or comments do you have? Yes, please.
So I finished the Inmed course in the fall of 2025, and I'm just curious as to how the trips work. If it's more of a rolling basis, or are there
Yeah.
significant times during the year
Sure.
where you really need to focus on taking
Yeah, how do the trips work? All of these sites run 24/7, and the faculty live there. And so essentially, they are available just about any time you are. And so you don't have to conform yourself to particular travel dates. Now, sites have a limited capacity, and so it's good to register early so we can get you into the place where you want to go. But they run all the time, so that's better for you. Yes?
So for the Inmed course, if we want to do like a preceptorship our third or fourth year, I'm assuming is when it would be.
Right.
Do we need to, I'm a first year, so would I need to take the Inmed course next fall then, or is it available to me like during my rotations my third or fourth year?
Okay, you can't do the course and the rotation at the same time.
Okay.
You'll need to do the course before you go, and most of the course is online anyway. Now, we're hosting the course here again this fall, but we also host it 5 times a year in other cities. So you can take it in Kansas City or Fort Worth or Los Angeles. So if you're willing to travel, you can take it almost any time. But we'll work with you on dates, that would be best with your schedule. Yes?
Are the teams interprofessional? Are there other disciplines involved?
Yes, other professions, and actually we have a track in medicine, which we have nurse practitioners and PAs involved with, and dentists and pharmacists, as well as our track in public health, which is open to undergrads and RNs and nursing students and dietitians and physical therapists. And we're very interested in collaboration among all of these groups because everybody brings an expertise that is especially valuable.
As as DOs, we are not necessarily known in the rest of the world or acknowledged being able to have the same scope of practice. Have you had any issues with DO students? Any of the sites or countries not allowing them to do the same things as other students or things like that? Or
Right. So, yeah, the question is about whether the DO recognition in other countries. And it is a process. There are a couple of nations in particular, Ghana and South Africa, don't recognize DOs, not yet. But most nations do. And what I do is when someone asks, what is a DO, I just explain to them that it's the same credential and standard and licensing as an MD, and it's no big deal. But not every nation is on board with that yet. So it's a good question to ask, before you go to a particular place. How about somebody from the course who could tell us about your experience? What was it like for you? Sure.
Well, so for the first 10 weeks, we do all everything online, and a lot of it is reading about new papers regarding vast aspect of international medicine. And something that I really appreciated was the cultural aspect, and seeing how that can incorporate how you practice medicine, and also what the nonprofits are doing in other countries and how they're funded, and just kind of the inner workings of these organizations that you ultimately will need to be involved with in order to do international medicine really well and make it sustainable. So that's something I really appreciated from the course.
Yeah, very sweet. Yeah, your class was so on top of it. Man, I just loved reading your essays and your disease management protocols. You were just doing great. Yes?
I didn't take the course, but I was just wondering how much of a need do you feel like it would be to try to incorporate more bioenvironmental engineers and like more, like, I know you have the Inmed course for public health degrees, but would you try to encourage us to seek like a full master's in public health or anything like that?
Yeah, should you do an MPH degree is a really relevant question. A lot of people who are working in global health do an MPH. I did one. Actually, I did it after I came home from Angola. It is a really fascinating experience. They are expensive, and but if you have the time and the money and want to do a master's, I think that would be great. All in all, I think it's better to actually go and work with a preceptor, work with a supervisor, somebody who can show you how it's done in that setting. That's by far the most valuable experience, is working with a role model. All right, well, we're about to wrap up here. I'm going to be around afterwards, and I did leave my business card and the event card at the back of the, and I would love to correspond with you or talk with you afterwards. So thank you so much for coming.